Hello, everyone. Thank you for having me today. I've been asked to come here and represent my role as an enhanced clinical practitioner. I've seen some really good examples of presentations, and they structure them under the 4 pillars. But for me today, it's really much about the journey that I've been on. So I'm going to be referencing the roadmap that's in the EUAC, which I think is really useful and user friendly. Do I need to press this next? Oh, it's here. So who am I? I consider myself to be a generalist with a specialist interest. That's to say that I'm interested in all body systems and all system diseases, but I've got a particularly affinity to looking after the care of the elderly patients, because for me, they are our most prevalent users of health service, as well as the patients who are most vulnerable in our communities. My professional background actually started in business and accountancy, and I worked for the Ministry of Justice in finance and accounting. But I found that role, whilst very important, quite unfulfilling, so I left there and came into nursing. I took quite a significant compensatory cut and started a role as a healthcare support worker in one of the wards in the Princess of Wales Hospital when it was under ABMU. The ward that I was on at the time went through some transitions from general medicine, endocrine to acute frailty. So I had, even at that level, a good level of exposure across different patient needs. And time was invaluable for me and was a great learning basis. And I went on then to do a healthcare support worker education, higher certificate, because my undergrad was too long away for my accounting and business management. And I did that through my employer and kept a substantive contract whilst doing my training. That went on to do the second and third year at Swansea University of the undergrad. And then I got a job in the emergency department in the Princess of Wales Hospital, which was invaluable experience for me and a great basis for my application for a clinical practitioner post, which allowed both me to have my generalist and specialist interest in care of the elderly. So without realizing it at the time, my journey in clinical practice actually started in A&E. Within the first couple of months, well, it was during COVID, well, before COVID, when the pressures were still quite high, I created a safety document for our ambulatory and ambulance patients. There was a document in place for ambulance patients, but it wasn't really fit for purpose. And often interactions with ambulatory patients who were unwell and needing treatment went undocumented, which allowed room for error, I suppose. The document was specific for these patients and was much smaller than the nursing assessments needed for patients when they went over to the admitting areas. I've always been quite self-driven and wanting to be able to work in all areas of the emergency department, so I pushed for additional training whilst I was there. I did postgraduate training around trauma care, as well as, well, I suppose ironically, given my current role, pediatric advanced life support. I worked mostly with adults, so doing this course gave me confidence to work with patients of all ages, and is still quite useful when dealing with adults, because children are just little people in lots of cases. I also pushed myself through to do the Manchester triage training, which gave me initial exposure in rapid history taking, as well as patient assessments, and ultimately advancing my skills around recognising clinical priority, as well as their deterioration and need for urgent treatment from both minor injuries and major presentations. And on the, which I actually find is a very useful, user-friendly roadmap, I think this was the start, where I feel, of level 6 professionalism. So my current role has given me great exposure. Our team provides a service across our entire hospital, so we're practically everywhere. Whilst elderly patients, given the nature of their frailty, can have ever-changing acuities in all of our areas, we have specific areas that have ultimately specific tasks when flow really allows for that. The acute frailty unit is a front door frailty service which looks after our most acute and newest admitted patients into the hospital, take from A&E and working mostly on AMU. We've also got 6 ward environments with specific tasks. So we've got a COTI Gen Med shared ward, a ward which specialises in sort of complex discharge and comprehensive geriatric assessments. We've got a ward which has patients with more higher levels of acuity who aren't dischargeable. So if they need to leave the AMU unit, they can go there. As well as a specialist ward looking after patients with challenging behaviours such as dementias and deliriums, but not excluding their physical conditions. So their assessments can be taken from head to toe holistically. And at the moment, our service is looking after 2 discharge wards that are community-led, but we're covering them. So because I started doing the role some time before starting my master's, I had valuable hands-on and major exposure with many presenting issues within our specialty. When I started, we had 8 advanced clinical practitioners from a varied background: nursing, mental health, physiotherapy, and we've got a paramedic now, with their backgrounds being in lots of areas like cardiology, trauma, physiotherapy, intensive care unit, and COTI experts. So how my training was structured initially is that I was allocated time with each of the advanced clinical practitioners to go through a single bodily system, which I suppose was a lot of on-the-job training. There was also, given the fact that our patients are multi-disease process, they have multi-disease processes, I had a lot of hands-on experience dealing with patients who have had strokes, COPD and asthma, acute infections like pneumonias and urine infections, as well as heart failure, diabetes, and other endocrine disorders. And just given the nature of frail patients with their acuity changes, the exposure of different levels of acuity have happened not just at the front door, but throughout all of our wards, which has been really fundamental for my learning. A key element of my training has been that around the geriatric giants. So the frailty syndromes, falls, immobility, frailty, polypharmacy, incontinence, confusion, and delirium. And for me, arguably the newest geriatric giant, in my view, is our social crisis. This is causing a iatrogenic frailty system, which is really difficult to manage at times. Interpersonal and therapeutical relationships. I feel as an enhanced clinical practitioner and advanced practitioners, we are members of a key member of the MDT, and we've got direct links with ward level and management level. We're trusted with concerns and are a point of information. We provide clinical leadership, able to act quickly with concerns raised by staff, family, or the patient themselves. And we're a permanent fixture on our ward. Unlike our medical colleagues who might rotate, we're well known to all of the staff in all of our areas. So even if we cross cover, we're a familiar face. Having higher levels of communication for me is the ability to talk about really sensitive subjects. Within my role, I am discussing things about care escalation and DNAR status, as well as breaking bad news, as well as sometimes having challenging conversations with specialities about referrals or requesting imaging. Oh, and there's me. I don't know if you can see, just going up a little bit more. That's the next step. So, like I said, we all know about the 4 pillars of practice, and for me, I find them to be quite interlinked, and they can one project can link with many different pillars. I've been involved in many projects, but some of the ones that I've specifically led has been that around bowel chart record keeping. Good record keeping means that complications can be easily recognized to reduce the symptoms for our frail patients, like delirium, patient discomfort, and ultimately surgical problems if they go on to have an obstruction, and prolonged hospital admissions, particularly for those patients as well who are independently self-caring but might have otherwise a cognitive impairment, because it's sometimes challenging to record those things. Another project that I led was around discharge at a glance. So it followed a discharge area, and I led the project to create a standardized language within the MDT. So what basically was happening is that nursing staff were seeing maintenance therapy as dischargeable, whereas therapists thought maintenance meant ongoing discharge needs. So creating the glanced view meant that anyone who was involved in the patient's care or needed to discharge the patient could do so more rapidly and safely. So that, for example, if they're red patients, then they're clinical. That's the reason for their current stay. If they're yellow, they've got ongoing needs for discharge from a therapy perspective. And if they're green, then all their needs from secondary care has been met, and they are solely social patients. And therefore, if their social care was met, they could be discharged. We've got a couple of projects that are currently in progress. I've had a little bit of time off, so they've been on hold, but I'm going to restart them now. One of them is around end-of-life care. Quite often we see the medical notes not for news, and I think it gives a wrong impression. So I want to say I am not for OBS. I am for OBS, but I'm not for news. And it's about making sure that we're recognizing patients' symptoms at end of life and documenting that written down. So the way I see it is, if they have had PRN medication, for example, then we need to know why. And if they haven't, we need to know why. Another one is around advanced planning. We're looking to promote the involvement of secondary care in advanced care planning, particularly for our patients that have got progressive diseases. What I mean by that is, I've seen a lot of patients who have, for example, an advanced dementia, and the families are not well informed about how that might progress, and therefore when the patient's deteriorating or their swallow stops, that patient's brought into hospital where they may not want that. So if we can catch it earlier, then we can prevent their admission and try and meet their individual holistic needs. I'm also looking to start I call it Practical Pracs 5-Minute Fridays, and what this will be is short snap educational videos that can be sent to staff on their own devices. It's not going to replace conventional education, but it's about creating that educational environment in its whole and using technology to support that, trying to mitigate things like staff shifts or staff being unavailable in one place at one time. I'm also in the process of writing a short survival guide for the newly appointed enhanced clinical practitioner, detailing basics that they might need to start off things like common blood interpretations, ECG reading, and management of our frailty syndromes. And then I just mentioned that I've completed the first year of the Masters. I need to do the second and the third and the IP. And this has given me some of the level 7 experience, level 7 education that I need to support my on-job training. But I believe that puts me on the next step in the EAC roadmap, which is gathering an evidence for the pillars of practice. So just moving a little bit on to my day-to-day on my journey. So having worked with the AACPs and getting that theoretical knowledge, improving my understanding around assessment, disease and management at a theoretical level, I went on to work really closely with one of the lead advanced clinical practitioners and the medical consultant for our ward, who ultimately was assessing and promoting my competence and improving my levels of autonomy. I currently work mostly on a practitioner-led ward, and I head the daily board rounds. I'm currently responsible for about half a ward, which is 14 patients, and I review them independently with direct support then from the consultant with any issues that I might have. But because it's practitioner-led and my lead ACP has the other side of the ward, there's practically daily case studies that I discuss with my ACP. It gives me great exposure. So with my patients, I can assess and investigate them. I'm able to independently request all sorts of things: biochemistry, microbiology, and imagery, ultrasound, CT, chest X-ray, MRIs. But more importantly, as I develop, I'm more competent in interpreting those results and putting medical plans in place for my patients. Naturally, because I'm yet to do my independent prescriber, any treatment plans is discussed with my ACP or independent prescriber that's with me, whether that's one of the doctors or one of my ACPs. I also give medical updates to the families, to the patients themselves, answer any medical questions that they have. Depending on our patient's acuity, our ward round with the consultant is weekly, once a week, and I'm key in supporting that, really. I give an update to the consultant medically and answer any questions that he has, or then go on to action any requests or further investigations that he might want. The wider holistic needs of our patients, such as discharge plans, therapies, and social concerns, don't typically fall within my current remit. It's a little bit more medicalized, but I'm a nurse fundamentally. And within my role, we are able to support particularly challenging discharges or complaints that families might have from a medical, nursing, or therapies perspective. So daily, I'll address the geriatric giants, as I've previously mentioned. If time allows, on a day-to-day basis, pretty much in the afternoons, then we can work on our QI projects, our other pillars, and our portfolios. So what happens with that side of things is currently our leadership will give us 1, maybe 2 continuing professional development days a month. But if you're working on a project or have particularly large workload from one of the other sides, one of the other pillars, then leadership can recognize this and they're a bit more flexible when it comes to CPD time. So ultimately, my aim is clear, but my destination is not. I know what I want to do. I want to improve the health provisions given to our communities that, as health professionals, we are part of the community as well as the health service. So it's in our interests to make sure our health services are better for our communities. Completing the second, sorry, I've missed a part. Right, so completing the second and the third year of the Masters and collating my portfolio, ideally online, will give me the evidence that I need to support my progression into advanced clinical practice in conjunction with the current, great basis of work-based learning that I've had. Mentoring newly appointed enhanced clinical practitioners will mean that what I've learned and continue to learn, I can share with the next wave of practitioners. Networking and building wider professional relationships across the MDT and across sites means that we can share good practice, not keep it to ourselves, and improve the outcomes not just for our local communities, but for Wales. And obviously, to improve my own autonomy, I need to do my independent prescribing. I feel the clinical practitioner role is in a good position between direct clinical practice on the shop floor and the wider pillars. Having a grasp on service delivery, I want to continue to develop this so that we can have a voice on what works daily for our patients at a board level. I think clinical practitioners are an interface between nursing, medicine, allied health professionals, management, strategic groups, and community settings. So we're a basis of information that could be utilized. And I want to influence the team that I work with, who again represent the communities that I'm part of. I want to gain further understanding of staff leadership through clinical support and direct line management. So just as a closing remarks, I've had quite a rapid development because I believe learning doesn't start in the classroom. You can learn every single day if you have the confidence to be wrong and to learn from it and to listen. You need to understand your own limitations and ask for support when needed to ensure our patients' safety. Have the trust of those leading you and developing you, be inspired by those around you, not just have clinical mentors, but career mentors. And having empowering leadership where you can see that your own achievements they're proud of and recognize as their own. I'm aware that having been the only trainee ACP in such a large team has given me a massive array of patients and exposure. And I think this has been fundamental to my learning and inspired me to continue to work towards advanced clinical practice. And that's it. Thank you.
We've got a couple of minutes if anybody's got any questions for Adam or Wendy is his manager as well as Adam. So anybody got any questions? Yeah? Thank you, that was a fabulous presentation.
Thank you.
Very much. I could ask you loads of things, but I was struck by what you said that you have some time in order to focus on the other pillars as part of your clinical role. And I just wonder, the time is. Oh, can't they hear me there? Sorry, senile moment. I repeat, that was a fabulous presentation. Thank you very much. you talked about being given time in order to focus on the the other pillars in addition to the clinical. And time is really precious, isn't it? You know, it's a limited commodity for many people. And I just wonder, how difficult was it to actually achieve that? Did you have to push, negotiate?
No, I didn't. I'm very fortunate with the team that I'm in, and I'm not just saying that because my manager's here. Wendy, Julie Hayes, the rest of the ACPs have been breaking down barriers years before I came. So lots of issues that have been around have been dealt with before I arrived. I have lots of ideas of my own. In fact, I have a list of them. I just don't have a lot of, with learning and developing and, you know, trying to enhance myself, I haven't got the time to do all of them. So I work on one at a time. But one of the things I've been speaking to my leadership about at the moment is particularly on our, I suppose, more medically stable patient wards, is reducing the amount of daily reviews that practitioners are doing and rely on our registered nurses to escalate to us, because at the end of the day, they are professionals as well. So it's about, I think, being more time efficient, being daily on the board rounds to there to answer anything that happened overnight, but not necessarily needing to do a full medical review on medically fit patients every single day. And then the time that you save doing that can be then spent on clinics or, you know, to support discharges or the wider pillars of practice. But I've not had any troubles getting time to do it.
Thank you.
Just add a little bit to that as well. In terms of sort of CPD time, what I tend to do with the team is factor in that CPD time into our rota. We do sit within, Adam explained, we take over probably half of the hospital in Princess of Wales, and we sit along some junior doctor colleagues as well. So we're a huge team. So there is opportunity to kind of plan ahead and give that CPD time. It's mostly sort of once a month, which isn't a huge amount, but that one day a month does give that time then for the team to take forward all these projects which are instrumental really in supporting and providing better patient care, because that's what we're there for essentially. So just wanted to add that in.
Adam, that was a brilliant actually presentation, and we are actually going to be contacting you afterwards because we want you to come on to Careersville just to demonstrate what the art of the potential is. Absolutely, really great. And it's interesting what you've just described, and actually following on from Shalette's question and what Wendy has said, is it's really great that you are factoring in that time, because let's be clear, our medical colleagues do that. So we've actually got to demonstrate that we need that as well in order to demonstrate that. So well done. And I think it's an exemplar really to take forward from everyone here to try and do that, because they do it and we can do it. Okay.